Hello everyone. Today I'm going to talk about advanced non-small cell lung cancer, advances in biomarker testing and immunotherapy. Learning objectives include to recognize the critical importance of making accurate diagnosis of non-small cell lung cancer, especially when dealing with small samples, to comprehend the significance of biomarker testing for gene mutations and PD-L1 protein expression, to understand how molecular testing plays a crucial role in guiding treatment decisions for lung cancer, to learn effective treatment strategies through analysis of classic clinical cases. Non-small cell lung cancer is the most common type, accounting for around 85% of all lung cancer cases. Over 40 to 45% of non-small cell lung cancer cases are typically diagnosed at an advanced stage, including locally advanced stage 3 and metastatic stage 4 disease. Non-small cell lung cancer is a complex and heterogeneous disease requiring tailored treatment approaches including molecular targeting and immunotherapy checkpoint inhibition. This presentation will explore the latest advancements in biomarker testing and immunotherapy for advanced non-small cell lung cancer. The timeline has been proposed for diagnosing advanced non-small cell lung cancer. Diagnosing lung cancer starts with 5 key steps. First, check patient history and do a physical exam. Second, use imaging like CT scans to spot abnormalities. Third, take tissue samples through biopsy or fine needle aspiration for diagnosis and biomarker tests. Fourth, analyze tissue samples to confirm cancer type. Fifth, perform biomarker testing to guide treatment. We strive for a faster turnaround time, aiming to report all results in 10 days or less. Precise diagnosis is vital, particularly distinguish between small cell carcinoma and non-small cell carcinoma, and between squamous cell and non-squamous cell types, which affects treatment decisions. Adenocarcinoma, squamous cell carcinoma, and neuroendocrine tumors are usually easy to diagnose in small samples. While grading adenocarcinoma is not necessary, identifying growth patterns is typically required. When the malignant epithelial tumor with a solid pattern is in small biopsies, TTF1 and P40 IHC tests are necessary to differentiate adenocarcinoma from squamous cell carcinoma. If P40 is positive, it suggests squamous cell carcinoma, while TTF1 or special stains conforming cytoplasmic mucin suggest adenocarcinoma. In cases where TTF1, P40, and mucin stain are all negative in small samples, it's referred to as non-small cell lung adenocarcinoma, not other specified. Lung cancer is typically staged using the TNM system, which assesses the size and extent of the tumor, the involvement of nearby lymph nodes, and whether the cancer has metastasized to distant organs. Each of these factors is assigned as a specific stage, typically ranging from 1 to 4. Advanced non-small cell lung cancer refers to late stage or advanced stage non-small cell lung cancer, typically stage 3 and stage 4, where the cancer has spread beyond the lungs to other parts of the body. Histological subtype of non-small cell lung carcinoma is very important, which will significantly impact the following decision. In advanced stage of the tumor, non-squamous cell non-small cell lung carcinoma is subjected to molecular testing, including EGFR, ALK, KRAS, RAS1, BRAF, NTRK, MET exon 14 skipping, and RENT, and PD-L1 IHC. In cases of squamous cell carcinoma in young patients, or a history of non-use or light use of cigarette tobacco, PD-L1 IHC needs to be done, and other molecular tests are considered. Here is the list for biomarkers, including EGFR, BRAF, KRAS, and HER2 gene mutations, ALK, RAS1, NTRK, and RENT gene fusions, and PD-L1, drug names, and date of FDA approval in non-small cell lung cancer. Given the growth of biomarker-driven therapies over time, the definition of what constitutes comprehensive biomarker testing for patients with advanced non-small cell lung cancer continues to evolve. Ideally, comprehensive biomarker testing should be conducted using next-generation sequencing panels. While other methods are available and acceptable, NGS often enables quicker and more efficient biomarker testing with reduced time and tissue expenditure compared to other assays and strategies. Laboratories should offer the choice of including RNA-based analysis or other complementary techniques, such as FISH and or well-validated immunohistochemistry like ALK. Cell-free DNA can be used to identify targetable mutations when tumor sample is insufficient or difficult to obtain. Immunohistochemistry is a necessary and a common technique for assessing PD-L1 expression. Our institute has adopted the Oncomine Precision Assay developed by Thermo Fisher Scientific, which allows us to detect specific targeting gene mutations, including EGFR, BRAF, KRAS, HER2, and MET, as well as gene rearrangements such as ALK, RAS1, RET, and NTRK. This NGS panel is reflexively performed when non-small cell lung cancer is in stage 3 or beyond in our institute. This is a spectrum of oncogenic driver mutations in the lung adenocarcinoma, with EGFR and KRAS being the most common prevalent, each accounting for approximately 26%. RAS1 rearrangements are seen in 2.7%, while ALK fusions occur in 3.9% of cases. Other genes also exhibit rare mutations. We are familiar with the mechanisms of EGFR, ALK, and RAS1 signal transductions in lung cancer. EGFR kinase domain mutations, including exon 19 deletion, L858R, and T790M, increase kinase activity of EGFR. leading to the hyperactivation of downstream signaling pathways, including MAP kinase, PI3 kinase, AKT, mTOR, and IL-6, JAK, STAT3, which promote tumorigenesis of non-small cell lung cancer cells. Activation of ALK and ROS1 signaling is rare in most adult tissues. When ALK and ROS1 fuse with partners, they get activated, resulting in activation of downstream signaling pathways, including JAK, PI3 kinase, AKT, and MEK-ERK, and they can promote cell proliferation and differentiation and provide anti-apoptotic signals. This patient presented with an unresectable lung mass. A needle core biopsy revealed adenocarcinoma with a papillary pattern. EGFR gene sequencing identifying an actionable mutation in exon 21. Following treatment with a first-generation EGFR inhibitor, the tumor disappeared. This is a 31-year-old female patient with non-smoking history. An MRI revealed a sacral mass leading to suspicion of lymphoma or sarcoma. However, a needle core biopsy showed adenocarcinoma with a positive TTF1 and NEPSON-A along with cytoplasmic mucin, consistent with a primary lung tumor. Subsequent chest CT imaging confirmed the presence of a lung mass a few days later. We performed FISH using ALK break part probes, which revealed a positive ALK gene rearrangement. Simultaneously, we were in the process of validating the specificity of the ALK antibody with the D5F3 clone. Immunohistochemistry results demonstrated strong positivity in the neoplastic cells. Subsequently, the patient was treated with an ALK inhibitor. In this case, an 85-year-old male with a history of radioactive seed implant for prostate cancer in 2001 presented with hematuria. Urine cytology raised suspicion for high-grade urothelial carcinoma. Subsequently, a transurethral resection of the bladder tumor was performed, and a pathologic diagnosis of high-grade PT1 urothelial carcinoma was confirmed. The patient also presented with a cough and a hemoptysis. Subsequent chest CT and PET scans were conducted, revealing a lung mass with positive mediastinal lymph nodes. Endobronchial biopsy was conducted, revealing a poorly differentiated carcinoma that tested positive for keratin but negative for P40, TDF1, GATA3, and uroplakin-2. The favored diagnosis is non-small cell carcinoma, not other specified, with features suggesting lymphovascular invasion. PCR sequencing indicated the presence of KRAS G12C mutation and absence of EGFR, BRAF, and MET mutations. Mutation profile does not overlap with that of a bladder tumor from this patient, indicating it is most likely an independent process. FISH tests showed negative results for ALK and ROS1 gene fusions, and IHC demonstrated no PD-L1 expression. Let's move to the final section on immunotherapy. Human cancer immunotherapy involving anti-programmed death 1 receptor and anti-programmed death ligand 1 and 2 antibodies have been extensively used in the treatment of different cancers. Antigen-presenting cells uptake antigens released from cancer cells and present them to T cells. Additionally, cancer cells can also present antigens to activated T cells through the MHC. Upon T cells activation, PD-1 receptors are expressed on T cells, inhibiting immune responses by engaging PD-L1 and PD-L2 on APCs and cancer cells. Therefore, monoclonal antibody mediates specific blockade of the PD-1, PD-L1, and PD-L2 pathway can enhance anti-tumor immunity. Furthermore, apart from binding to PD-1, PD-L1 also binds B7-1 and PD-L2 binds to repulsive guidance molecule B. These interactions occur not only with T cells and APCs, but can also be induced on other immune cells. This is a 64-year-old male patient who had left arm weakness and difficulty in walking straight, which prompted the MRI of the brain. The MRI shows a 14 by 9 by 16 millimeter enhancing lesion in the hilar anterior right parietal lobe at the cortical margin, with pronounced surrounding vasogenic edema, and the lesion likely contains some internal blood products and all necrotic debris, and demonstrates a somewhat thickened rim. A neoplasm is leading differential consideration. He noted difficulty breathing for a few months. He also reported coughing up blood for a few days. A history of tobacco use was noted. Both the brain mass and respiratory symptoms prompted chest CT examination. Chest CT shows a 3 cm left up lobe, hilar centrally necrotic mass, concerning for a primary lung malignancy, and ipsilateral metastatic mediastinal lymphadenopathy with AP window lymph node measuring 3.4 cm. Needle core biopsies of the lung mass revealed a non-small cell carcinoma favoring adenocarcinoma with a positive TTF1 result. No EGFR mutations were detected, and there were no ALK or RAS1 gene fusions found. Immunohistochemistry demonstrated high PD-L1 expression. The patient was initiated on treatment with PD-1 inhibitor, pembrolizumab. Before evaluating the effectiveness of PD-1 inhibitor on this patient, let's delve into the detailed discussing of PD-L1 immunohistochemistry. In the case of non-small cell lung carcinoma, we typically utilize the 22C3 clone. TPS is defined as the percentage of viable tumor cells, displaying partial or complete membrane staining at any intensity. A minimum of 100 viable tumor cells in the formalin-fixed, paraffin-embedded tissue slide is required for the specimen to be considered adequate for PD-L1 evaluation. Staining is best assessed at 20 magnification. Expression levels are characterized as follows. TPS less than 1% interpreted as no PD-L1 expression. TPS 1 to 49% interpreted as low PD-L1 expression. TPS equal or more than 50% interpreted as high PD-L1 expression. Based on these findings, medical oncologists can make informed choices to optimize the use of PD-1 inhibitors. This patient we discussed has stage 4 non-small cell lung cancer. Following the confirmation of the pathological diagnosis, gamma knife stereotactic radiosurgery was administered, and pembrolizumab was initiated. After radiosurgery and several cycles of the PD-1 inhibitor, MI revealed approximately 6 mm lesion in the right precentral gyrus. After nearly 13 cycles of PD-1 inhibitor, chest CT scans revealed a significant reduction in sizes of the lung tumor and metastatic lymph node, indicating that PD-1 inhibitor was highly effective. In summary, after this lecture, I hope you will gain a comprehensive understanding of advanced non-small cell lung carcinoma and recognize its complexity and the need to tailor treatment approaches. You will learn how to make accurate diagnosis and perform biomarker testing in the limited tissue samples, identifying actionable mutations, and provide evidence for precision treatment. Additionally, you will become proficient in conducting IHC to evaluate PD-L1 expression, guiding medical oncologists to optimize the use of PD-1 inhibitors. Finally, I would like to express my gratitude to my former trainees, Dr. Wu, Dr. Randy, and Dr. Ku, who contributed to the review article. Dr. Ran, who worked with me on the project, correlate ALK protein expression with ALK gene fusions, as well as to all the authors whose publications are discussed in this presentation.